Now, could I ask the other speakers to come and join us up here? And I'd also like to introduce Barbara Cassidy from BHF professor at Oxford University, who will be joining us on the panel and who has been one of the leaders in Biobank on the iRhythm studies. Now, let me just remind you that if you have a question, you can either write it on one of these sheets of paper and just hold it up and someone will collect it, or raise your hand and we'll get a microphone to you. But this is it's a great opportunity to speak to the speakers thus far, and then we'll have a chance afterwards also to speak to Rory Collins again and Mike Rollins. I'll open it with a question that came earlier, and I think this is the right panel to answer this one. So, which is the hardest nut to crack? Reese, is it trying to understand cancer and how to treat it, brain disease, or the heart? How are people going to fall out on this? No one asked about fat. Okay. Any thoughts about this? Could Nick, you started to present the interdisciplinary focus from can you talk about whether we should be thinking about the challenges of each individual disease or the body as a whole, or how would you address this?
Yes, I note that bone wasn't included in that, but I think bone is very difficult as well. And I think clearly there's an important issue of the organ systems and diseases in their own right. And individually, there are major challenges, some of which are kind of common across all disease areas, and there will be things to do with numbers and how well you can classify and get the phenotype. But there'll also be specific issues to the individual diseases. But I think as I mentioned when I spoke, the real value of UK Biobank is in the exquisite level of phenotypic information we have about all of the participants. And that goes right back to the baseline screening, which of course is repeated at the imaging visit. We have the genetics and the biochemical and other markers linked to this very comprehensive suite of images. And then of course linked to the incident outcomes. And so I think, of course, there are individual difficulties, and I guess bringing that all together to look at interactions between diseases probably magnifies the difficulties in some ways. But it is a unique opportunity, and I'm sure that bringing everything together in this way will give us really novel and groundbreaking insights, not just into disease pathogenesis, so why diseases happen, but also into ways in which we can assess risk. For example, that's a very big thing in preventing osteoporotic fracture. But how we can maybe amalgamate approaches to assessing risk of, say, fractures along with heart disease and so forth, to get a more comprehensive view of an individual's risk going forward.
Yeah, I think that's a good answer. I mean, the real challenge that I think all of us are seeing is the hardest nut is actually addressing chronic disease as opposed to acute disease. And that's what is transformative about this sort of interdisciplinary thinking. We've heard a lot about the imaging here over the last short time as one of the enhancements. We saw some fabulous results, Stefan, from your work already. Really important results about statins, for example. You showed how much you can do with 5,000 subjects. Why do we need 100,000?
So I think with 5,000 you can do very nice cross-sectional data, but that doesn't necessarily tell you what's causal. So I think for that, the prospective nature of UK Biobank will be very important. And also for some maybe rarer conditions, cardiac conditions, you may not see that many outcomes, and then you need 100,000 imaged so that you can identify in 10 years 5,000 that developed a certain condition. So I think for that you need large numbers. And also I think what is very exciting is to try and understand the heart structure and function and the relationships to the genetics more. To what proportion are they determined by things like statins, air pollution, high blood pressure, and to what proportion are they actually genetically determined? For that, you need large numbers. 5,000 won't be enough.
Anyone like to contribute to that?
I can make a quick comment. I see it. In UK Biobank, you get two types of studies in one. One general population like study on that allows us to see the general patterns of association between metabolic disease and other aspects. And then when you reach 100,000 subjects in the imaging study, you close the gap to the disease-specific questions. You have enough patients that has both diabetes and a cardiovascular event, and that mimics a clinical situation. And now we have it in one common data set where you can track all the paths in between general population medicine down to the disease-specific medicine.
No, I think that's true. I mean, I must say I can't help but remember Rory's comment to me when I asked why 100,000, and he said, well, because we can't do 1 million. And I think it is true. I think we all are different, and the larger the number of people we are able to study, the more refined the nature of the data and the predictions will be that results. But this really brings us to a theme that's been running through the day, and that's the impact of what Biobank is discovering with the help of many of you who are participants. Could I ask, Barbara, could you start to comment, and I think I'll go around the panel, on the potential impact that you see of this kind of information on the NHS and the way health is delivered, healthcare is delivered?
Thank you. I think it is fair to say that, well, I'm particularly interested and involved in the heart rhythm monitoring. So the cardiac, specifically the cardiac rhythm aspect. And I would say that as cardiologists, we have some coordinates and some evidence that guides what we do in the case of rhythm disturbances in association with symptoms. So loss of consciousness and or heart failure associated with a rhythm disturbance. Now, when this rhythm disturbance occur in the absence of symptoms and they are picked up serendipitously, what you do depends very much on how risk averse you are. You know, you could decide to treat because you don't have evidence that not treating is not a bad thing, or you can decide not to treat. So it's a completely haphazard. So my hope is really that through this long-term monitoring, which will identify this asymptomatic arrhythmias, we would then be able to follow up these patients and find out what this asymptomatic arrhythmia mean. We would also be able to refine the risk stratification of patients, say, with silent atrial fibrillation. At the moment, we know that the score that we have that predict the stroke risk, it's okay in a population and performs quite poorly in individual patients, and we have so much material in UK Biobank that we have the hope of refining that. And finally, we know that for instance, again, silent form of atrial fibrillation seems to be associated loosely, so not in a temporal way, in terms that sometimes the atrial fibrillation can happen before or after a stroke. And we don't know what is the nature of these strokes. Are these embolic strokes? Are these other strokes? So in other words, is atrial fibrillation the cause of these strokes, or is it just a biomarker of an increased risk of strokes? So you can see that the way you then manage the patients would be completely different, because the atrial fibrillation may or may not be the culprit or the target of treatment. So these data have the potential of having a huge impact in the way that we are managing patients in the National Health Service, and in the way that we risk stratify these patients and we stratify the treatment.
Judy, would you like to elaborate on that based on the experience that iRhythm has had in this specific area?
Thank you. I was just going to add on to Barbara's point about asymptomatic arrhythmias. What we have found in our database of over 750,000 patients, that only 18% of the arrhythmias detected are actually symptomatic. And our database, we find in the records, 72% of all records actually have at least one arrhythmia. But to Barbara's point, what does that mean? How does it change clinical practice? Now that we're starting to understand that maybe there are sinister arrhythmias that are not being captured that actually are also causing sudden death? Or are there just arrhythmias like supraventricular tachycardia that we all experience because we're so caffeinated? So again, it's just something we're all trying to understand, but we need these large data sets to really help us understand.
Now that's really helpful. Now, speaking of the large data sets, I think, Jimmy, you started to walk through a rather dizzying array of ways in which we can modulate fat in different portions of our anatomy. But can you really help us focus in on, again, on what the importance of linking these kinds of measures with understanding of nutrition, activities, employment, and so on?
Yes, I think it's numbers become very important when it comes to kind of diseases we are looking at. You know, things like type 2 diabetes, coronary heart disease. These are diseases that have been affected from the moment you were born. Even the size of yourself when you were a baby, what weight you are, what your mother was doing when she was pregnant. All these affect your risk later on, what you ate last week. So 100,000 appears to be a large number, but Rory is absolutely correct. If you divide that 100,000 into male and female, you only got 50,000. And then you divide it by BMI, you end up with about 5,000 each. And then you look at physical activity, and suddenly you're only looking at about 20 people. So it's actually quite important. So then if you want to superimpose the genetic on top of that, and you want to look at the interaction between your diet, your physical activity, your genetic, your background, and then the numbers become very, very important, and the statistics become very, very important. So even for us, simply in what Olaf showed early on, with about 6,000 people, we left the computer to decide how many groups of people we have in body composition. It came out with 8. And then you can superimpose genetics and lifestyle upon those 8, and then start understanding risk factors. And what's important is progression of disease as well as acquiring a disease. Some people progress very slowly, we don't understand why. Some progress the type 2 diabetes in a very aggressive way. Those people need to be treated differently to those who progress slowly. Where do we put the priority? Where do we put the effort? We hope that UK Biobank will answer those questions, and I think it will. I think it's already doing so.
Are there other comments from the panel? Perhaps, Kathy, could I ask you to pick that up? I mean, you, in a slightly different context, you emphasized some of the challenges of having a veridical diagnosis, having a true diagnosis based on single data sets. And I know that was a question that came up in the audience. How does the richness of the data and the ability to cross-link it really help inform your attempts to understand what it is exactly that is wrong with an individual?
Well, I'm going to answer a slightly different question, and that will maybe come back to that, Paul. So I think the really critical thing about UK Biobank is its prospective nature. So we've heard a lot of really tantalizing information today about associations between one thing and another. For example, Jimmy's really interesting associations between liver fat and cheese consumption, for example, and the interesting shape of the relationship between alcohol consumption and variables that you measure in the liver. Was it liver fibrosis or liver fat? I can't remember. But anyway, but what's really critical about Biobank is that we can actually find out whether these associations are causal or not. And we can do that in two critical ways. One is using the genetic information, and we heard from Andrew Hattersley earlier about how critical genetic information is in informing us about causality. And the other is the long-term follow-up. So we have recruited people who, by the large part, were healthy at the time of their recruitment. And as they're followed up, some of them will develop disease and some of them won't. And all of the information that we have, the imaging in particular, will help inform us, firstly, whether these associations between lifestyle, environmental exposures and so on are causal, because we've got the chicken before the egg, but also through detailed data collection exercises like the imaging, how those manifestations occur, what are the mechanisms by which those causal pathways lead to the development of disease. And it must surely be through those types of routes to understanding that we'll gain better insights into the ways to prevent and treat a whole range of different diseases which we can detect in Biobank using those health record linkages.
No, that's very compelling. Let me just ask one more question before inviting Rory up and Mike Rollins, if he would be willing to come up as well for some final thoughts. And actually turn to you, Olaf, in this context. So so that star diagram that you showed, I just want to emphasize for those of you who didn't think about it, but that's an entirely novel diagnostic approach. It's not something that we're familiar with in the clinic. You're inventing it from the data that you're seeing. Can you comment on the challenges of that and why data sets like the UK Biobank really become so important for it?
Tricky question, but I think I start in the earlier comment about the importance of being able to describe what's normal, what's healthy, starting that and describe the whole population, the basic confounders of the variables. That's the population level description. We need to know what it means to have a healthy result of an examination. And then if we want to take it the whole way to a diagnostic technique or risk predictive technique, then we need the other end. We need to know, if we again take that example, how's the body composition profile for diabetics with cardiovascular disease? And the ability to access all of this data with all the linkage to health outcome data is really a new opportunity that we see in UK Biobank is the only resource that can provide today.
No, that's fantastic. And so it's, again, another tribute to all of those who've helped make it. Let me sort of bring us towards a close now, unless there are any questions that we've missed thus far. Yeah, please. Microphones are coming.
Hi, Sarah Lee, medical imaging analysis consultant. I have a question in terms of the quality of the imaging data. From last year's paper on the neuroimaging result, we saw that the percentage of imaging that passed the quality control is around 90%. I mean, I don't want to change my memory now. I just wonder whether other presenters can comment on all the imaging, for example, the body fat and also the heart imaging and bone imaging. What would be the percentage of the data that would be analyzable?
So just let me repeat that to make sure that I understood. It echoes a bit in the room. So the question is about the data quality for the imaging data sets, and to try to just estimate what quality of, what the proportion of the images are that really can't be used.
Yes, that's right.
Yeah. Could I maybe start with you, Stefan? You've looked at this closely.
Yeah. So for the cardiac imaging, for the heart images, we have obviously analyzed those 4 chambers, which is only part of what you can analyze. The data there, if I remember correctly, is that about 3 to 4% of the hearts that were imaged of the 5,000 weren't analyzable to get reliable left ventricular volumes. For the right ventricle, it's a little bit higher, that number, because you often need to acquire an extra slice, and sometimes that's been missed off, that baseless slice. So that's about 8%, I think. But overall, it's very, very good. For the atria, that number was around 8% as well, and that's because actually this is sort of like a nice side effect that we can look at the atria. It wasn't designed to measure the volumes of the atria, because we only have 20 minutes. We had to actually, cut our losses, and we said, well, we get some information, but we take into account that sometimes we're a bit off axis and we don't get it perfectly. So I think the quality is very, very good. There's lots of other parameters like the tissue characterization, the tagging. We haven't quite got there, so we are in the progress of analyzing the 5,000, but overall we are very happy. Now, I am a little bit concerned, I think we are working very, very closely with a group in Sheffield that tries to, and I know in Imperial there's another group interested, there is no automated tools of detecting the quality of the images as they are acquired. And we are working very hard to try and find solutions that can still be implemented, so that we know that for the remaining 85,000 now, we will have very, very low failure rates. And I'm pretty confident we can achieve that. So it's very good. We need to keep it good.
Jimmy, would you like to comment, or Olaf? Actually, Olaf, perhaps you were ready to comment first on abdomen and liver.
Yes, we published a paper in PLOS ONE together with Jimmy here last year about the results in the first 3,000 participants in the imaging study. And we were able to achieve very high success rate, especially in the abdominal part of the protocol, with visceral fat and abdominal subcutaneous fat quantification success in 98-99% of the subjects. Looking at the muscles, somewhat lower just because of the time constraint of the protocol. The tallest subjects don't fit within the prescribed protocol, and so we have some volume loss. Liver fat assessment holds a similar level of result. Another comment here is really what you're addressing, that we need someone that inspects and curates the data. At least from my perspective, if we want to develop individualized methods that look at the specific combination of the imaging phenotype, the genetic data, we need to rely on every data set. So it's not okay to have 3-4% of the data sets in there with values that are completely off. So we really need to know if the data set is good or bad, and for that, at least from our group is working with manual quality assurance of every data set and removes whatever data set don't fulfill the criteria.
Yeah,
So can I just add one thing? I think it's important to say that you get information from every data set. So we have been very strict. When we say we get 97%, we mean we get all the data out of 97%, but we get some data from 100%. So that is the difference. So if you think that we've done 15,000 people and 95 to 99% you're getting very good data, it took me 15 years to scan 1,200 people. The UK Biobank did that in a year. So, and the quality of the data was as good or even better than what we had. So that is, I think it's actually quite important when we are perfectionists and we like 100% of 100%. Yeah, we go 100% or 97%, so that's actually important.
Yeah, and I think what Jimmy has said holds for the heart too. The real challenge is maintaining the precision of the data in the highest possible form in terms of its consistency, and also in these very challenging protocols, making sure that everyone can get through the rather long sequences that are available. I think we won't probably go on to DEXA unless you have a particular comment. DEXA is a much more standard technique, and the success rate has been extraordinarily high from the beginning.
I mean, just to say that there's not really a failure rate in the same way as with MR, but in terms of the measures, and you plot the measures out because it's a quantitative technique for the main, and the number of outliers, it is a handful, so less than 0.1%, so very good quality.
And ultrasound, which is most challenging because it's very manual. Also, there is a QC procedure which has been in place and it's been enormously successful. Let me close this section of the meeting, and I think just for ease, if the panel wouldn't mind, they could stay here for the final minutes. I wanted to invite Rory back up, and also Mike Rollins, if you wouldn't mind joining us one more time. And I wanted to close in two ways. One is by just leaving a question with Rory and Mike to address serially in their own way, and then leave it to Rory to close. And the question I have, this has been a hugely exciting project, but we've talked a lot about disease, but can you comment on what you think the significance of these sorts of findings are going to be in helping to guide us to healthy aging, as opposed to worrying about what disease we're going to have?
Well, yeah, shall I start off? I'll just give you one example. I won't go into the reasons why, but not a year or two ago, I had to have a DEXA scan to see if I should take biphosphonates. Now, the problem is that the DEXA scan and the risk of fracture have all been worked out in women. And they haven't yet worked it out in men, so I'm relying on you guys to sort this out, for God's sake. So next time I have a DEXA scan, I'll get some data based on fact. But I think that's a sort of healthy aging example that will work and be very helpful to me anyway, because I don't really want to take a biphosphonate if I could possibly avoid it. So anyway, Rory, you've got a better answer.
I never have a better answer than the chair. I just wanted to thank everybody who's spoken, everybody who has come along. I think the key thing with UK Biobank is to understand that it's an experiment in a number of different ways. It's an experiment for the researchers using it, but it's also an experiment for the people building it. How can we build on this scale? How can we improve the quality of the data? So learn from our early experience to make it better. What are the things that we could do as UK Biobank that would help the research community? So a lot of the things we are doing have come from researchers saying, what about doing this? We were doing the recruitment, and Moorfields Hospital scientists said, what about eye disease? And so we added in much more about eye disease. And you've seen a number of ways in which the resource has been increased in value by researchers around the UK and the world saying, how can we make this experiment better? But I think to close, I see us now as being kind of halfway. As a researcher, the complaint has usually been, I haven't got enough data. What we've done now is we've flipped it. And the problem we have now is we have too much data. We have imaging data that is on a scale that, as Stefan pointed out, in the heart, that is bigger than people are used to dealing with. And as he's also demonstrated, if you build it, then they will come. If you create a problem, then people will come up with solutions to that problem. How do you automatically analyze cardiac imaging data? Now, that'll not only be useful for UK Biobank, but it's likely that that will be useful for the NHS as a way of automatically analysing cardiac images that are being used for other purposes, similarly with the cardiac rhythm examples. But biomedical researchers are not going to solve this problem of too much data. And so what we're seeing is the need to have a much wider collaboration between many different kinds of scientists to solve the problem of too much data, turning that into information about the relevance of those data to both disease and the flip side of disease to health. And so I think we've created the problem in the last 10 years. and we're going to solve the problem in the next 10 years of understanding these data and understanding the determinants of disease through the collaboration of the participants, and again I'd like to thank them, of the researchers who helped to build the resource, and the even larger number of researchers around the world who are working out how to use that resource. But if you have ideas for the ways in which we could do it better, whether you're participants or researchers, then we're very open to working out how to do this better. Because like any good project, at the end of it, you know how to do it. At the beginning, you don't know how to do it. You learn as you go along, and we're very interested in learning how we could do this better. So if you think about things afterwards, or if people are watching this on a webcast and have ideas, please let us know. How could we communicate better? How could we engage participants better? How could we make the data more easy to use in order to improve health? And again, I'd like to thank the panelists here, all the other speakers, and you for coming along. And I think we now have Andrew has been brewing tea and cooking cakes, and they're out there for us. Thank you.